We are live now, sir. Welcome to Orthopedic Online Educational Webinars. This is Dr. Shamswada from Patna. We would like you to thank all our faculty for sharing their knowledge and expertise with all, especially in such challenging times. We wish all our audience a healthy and safe days ahead, and we hope these webinars add value to your time. These webinars are dependent on internet speed, which might be at times unstable. Please bear with us for any issues with internet. Today we have Jharkhand Orthopedic Association webinars. The theme is Musculoskeletal Oncology. Now we can start, sir.
We should start now.
Yes, sir.
Yes, sir. Please, sir. Please start, sir.
Good afternoon, my friends. My greetings, everyone, on this International Yoga Day. I, Dr. Ashok Kumar Barnwal, welcome you all in this webinar of Jharkhand Orthopedic Association, JOA 3. The topic today is Musculoskeletal Oncology. This part of orthopedics we know is less explored by ourselves, and this definitely need more and more concern in days to come. We have very good faculty speakers today. First, I welcome Dr. Yogesh Panchwag, sir.
Thank you,
a
sir.
practicing orthopedic oncologist in Pune with more than 20 years of experience. My regards, sir.
Thank you very
I
much.
know people say your first appearance itself gives confidence to a patient. He is a visiting fellow in orthopedic oncology, Royal Orthopedic Hospital, Birmingham, UK, and also he is a founder member of Indian Musculoskeletal Oncology Society. I welcome Dr. Professor D.P. Bhushan, a gold medalist, and our president, Sejcon. He is a man always recognized for his organizing skill. Our students love him for his special interest in teaching. I welcome Dr. Kaushik Nandi, a renowned plastic and cosmetic surgeon from Kolkata, which shall definitely be benefited from his inputs. I welcome Dr. Alok Chandra Agarwal, sir, HOD Orthopedics in AIMS Raipur, who has spared time from his busy schedule for being with us. I appreciate him for his in-depth knowledge and excellent clinical skills. I do welcome Dr. Anant Garg, a practicing orthopedician from Apollo, Kolkata. Nonetheless, I appreciate Dr. Rohit Lal, our Joint Secretary, Jharkhand Orthopedic Association, who has contributed a lot for this webinar. I welcome Dr. Rajiv Raman, who has kindly consented to be moderator of this webinar today. I appreciate Dr. Ashok Syam and Dr. Samsul for their technical support. Finally, I ask and welcome Dr. Govind, our Secretary, Jharkhand Orthopedic Association. Dr. Govind, please.
Oh, thank you, sir. So, good afternoon, everybody, and thank you very much for your presence here. Now, I welcome Dr. Yogesh to present your presentation, sir.
Okay. Thank you, sir. All right, so I've been given about 15 minutes to cover the topic which is titled as limb salvage in osteogenic sarcoma. I'll try my level best to finish in time so that we can have a fruitful discussion over the cases later on. A few basics. We know that osteosarcoma is one of the most common primary malignant tumors of the bone. So many of us are going to encounter a case of osteosarcoma sooner or later in our practice. These are the cells which actually the neoplastic cells which produce osteoid matrix directly and is typically found in more in males, tends to affect the metaphysis more than the diaphysis with a ratio of 90% to 10%. The estimated incidence in India is supposed to be somewhere between 2 to 3 million, 2 to 3 cases per million per year. So that's about 3,000 cases in India, within India itself per year. We have a bimodal distribution, meaning by we see cases which are in their late teens, around 15 to 20 years of age. And then we have a second peak of osteosarcoma, which we see in the 5th decade of the patient's life. It can affect any part of the body, any bone in the body, but commonly seen in around the knee joint, in the proximal femur, in the diaphyseal area, in long bones such as the femur. We know that radiologically there can be various appearances. It can be purely lytic, it can be purely sclerotic, or it can have a mixed lytic and sclerotic appearance. One of the most important investigations that we rely on as far as the local staging is concerned in osteosarcomas is an MRI scan, which we sort of prefer to get a contrast enhanced MRI so that we can have multiple information such as the exact intramedullary extent of the tumor, the extraosseous extent of the tumor, whether there are any skip lesions in the bone when we scan the entire bone, including the distal and the proximal joint. We get to know what is the status of the surrounding muscles, what is the proximity of the neurovascular bundles, and so on and so forth. So there's a lot of information that we get to know from the MRI scans, which we also use to plan our biopsy. X-ray chest is able to show us metastasis only when the metastatic pulmonary nodules are more than 2 centimeters in size. And the distant staging investigations basically of choice currently are a CT scan, a plain CT scan of the chest with thin slices, which can show us nodules as less as a few millimeters in size. And the other skeletal staging investigation is a 3-phase bone scan, as compared to a PET scan, which is one of the latest investigations. The problem with the PET scan currently is the specificity. The PET scans do lack the specificity. They don't show an FDG uptake in lesions less than 1 centimeters in size, and that is where the problems start coming in. So for distant staging osteosarcoma, we still prefer a plain CT scan of the chest along with a 3-phase bone scan. Once we have done the local and the distant staging in a suspected case of an osteosarcoma, we start treating the patient only after we have a histopathological diagnosis, after we have performed a biopsy. Just to give you a short idea of how you should be doing the biopsy, it should be the shortest route to the tumor. We should be violating only one compartment as we approach the lesion. We should remain away from the joint and remain away from the neurovascular bundle. Try to avoid any joint contamination, and more importantly, stay in line with the proposed incision for the final limb salvage surgery, because this particular biopsy tract we consider to be contaminated and we remove at the time of final resection of the tumor. Well, how are we treating these particular osteosarcomas currently? Chemotherapy was introduced only in the late 80s and early 90s in India. Before that, most of our osteosarcoma patients used to present late, end up having an amputation. Eventually, they would have metastasis, and eventually almost all of them, maybe less than 10% would survive, more than 90% of them would die. But in the late 80s and early 90s, we started getting access to good chemotherapeutic agents. We understood the principles of limb salvage better. We had good quality implants available, and also the expertise and infrastructure started improving within India. So nowadays, what we are looking at is the diagnosing the patient early, treat them with neoadjuvant chemotherapy, operate them, resect the osteosarcoma in the extremity by doing the limb salvage surgery. And in almost 50% of our patients, we are now able to achieve a cure. That is, the patients are totally cured of the disease on a long-term basis. So when we are talking about a limb salvage in a high-grade sarcoma, the question that we face most of the times is that will it not compromise on the overall survival and the local recurrence rate in these particular patients? And this particular question has been safely answered by a lot of studies and papers that came out in the late 80s and early 90s again, and which showed that if you do the surgery properly and if you give adequate chemotherapy, there is no statistically different difference in the rates of local recurrence as well as overall survival in the patients of osteosarcomas. And that is what emboldened us, and we started doing more and more limb salvage surgeries, to the tune that most of our surgeries now, to the tune of about 95%, are limb salvage surgeries, and less than 5% are actually amputations. Osteosarcoma is one of the lesions where we would definitely treat the patient using neoadjuvant as well as adjuvant chemotherapy. Initially, this was started so that we could get some time for manufacturing the customized endoprostheses. But now the endoprostheses are available off the shelf. We don't have to really wait for them to be manufactured. But as we were waiting, we found out there are a lot of other advantages of giving the neoadjuvant chemotherapy. The surgery would be easier, the extraceous tumor component would shrink, the vascularity will be lesser, the satellite lesions in the reactive zone around the tumor would be sterilized. And obviously, once we resect the lesion and send it across to our pathologists, they will be able to give us the evaluation of the chemotherapy response, which will decide the prognosis of the patient. In osteosarcomas, what we do is we treat the patients with wide resection. We used to do a radical resection beforehand, but we have stopped doing it now. Intralesional resections or marginal resections are a strict no-no in osteosarcomas. So what do we mean by a wide excision? When we resect the bone, we have to be at least 3 centimeters away from the intramedullary extent of the tumor. If you have an extraceous soft tissue component of the lesion, then we have to keep a healthy muscle margin on the soft tissue mass. And we prefer to have a natural barrier like the joint cartilage or the physis or the cortex, if we can, so as to improve our margins, because now the quality of the margins is equally important to the quantity of the margins. As far as the neurovascular bundle is concerned, we can just leave the fascia of the neurovascular bundle onto the tumor if it is really very close, and that itself amounts to about a centimeter or centimeter and a half of margin if you want to convert that into a quantitative margin. Well, who are the patients whom we select to do a limb salvage? There are many multiple factors that decide that. First and foremost is that whether the patient has got any metastasis or not, because if the patient has presented with metastasis, it means a poor prognosis for the patient. We have to assess the salvageability, about which I'll be speaking in the next slide. And obviously, in cases and in patients like ours in India, we have to think and give a lot of importance to the socioeconomic status of the patient as well, as to what we are going to do for that particular patient and family. So who's an ideal candidate for limb salvage? It's that patient where we are able to achieve a good margin. We are going to be able to resect the tumor completely, and we are going to be able to leave behind adequate muscle in the limb so that it can give a good function to the adjoining joint. And obviously, this patient is now expected to complete the chemotherapy and the entire treatment later on. So it's a fine balance that needs to be achieved between saving the function in the extremity and controlling the disease. But one has to remember that under no circumstances, the disease control can be compromised so as to save the function. There are always patients that are going to present to us late. One can try to be godly, but we cannot be gods. So in such type of tumors, we have to be realistic in setting goals. And these are not the ideal limb salvage candidates. These have to be treated by an amputation. If we want to talk about the absolute barriers to limb salvage surgery in osteosarcomas, there are actually only two. One is where there is an encasement of a major motor nerve in the extremity. And number two is if you are not able to leave behind adequate muscles after resection, which can give an adequate and stable function in the adjoining joint. So these are the only absolute contraindications. Everything else, like badly placed biopsy scars or presence of a pathological fracture, all these are now considered as relative contraindications. So typically when we resect the tumor, there is a large defect, as you can see in the picture, that is left behind. And this particular defect has to be reconstructed. The reconstruction is expected to be stable, mobile, and durable, so as to give the maximum functional outcome to the patient. And there are various methodologies by which we can do this reconstruction. It could be an customized endoprosthesis, or it could be a modular endoprosthesis. It could be arthrodesis, it could be a rotation plasty, or it could be an extracorporeal radiotherapy reimplantation. And we are going to see an example of each and every case in the next few slides. So this particular reconstruction option is decided as per the patient's age, the site of affection, the demands of the family and the patient, and the expertise and the infrastructure that is available at our centers, and obviously the finances that are available to the patient. Megaprosthesis is the most commonly used reconstructive modality. There are various options, both indigenously manufactured and the imported ones. And that's a case of a distal femur osteosarcoma that has been resected with good margins. And reconstruction has been done by using an indigenously manufactured endoprosthesis. And you can see that these patients are able to have a 90 degrees knee ROM with good extension, no extension lag, and they have an excellent gait as well. So typically these particular patients, you cannot even make out which leg has been operated. Proximal tibia, likewise, osteosarcoma has been resected, reconstructed using a megaprosthesis. And here as well, you can see that barring there's a little thinning of that particular limb, the patient has an excellent functional outcome. If the disease is extra-articular in the, intra-articular in the knee, we can do what we call as an extra-articular resection, whereby we take out the lesion completely with the joint and do a composite type of a mega processes, where again it's a safe margin, oncologically safe margin, and the patients can have an adequate function. Proximal humerus is again another common site where osteosarcomas can be seen, and here again the principles are the same. The problem here is since we have to resect the rotator cuff muscles and the axillary nerve, because most of our tumors will have an extraosseous spread in the proximal humerus, the patients typically don't have a good shoulder function. What they have is an excellent function in the elbow and the hand, as you can see in this particular girl, but they lose their shoulder function. But we have to remember and tell the patient that this has to be compared with an shoulder disarticulation, which she would have otherwise ended with, and not the normal contralateral extremity. Sometimes we do get patients where an sarcoma has been inadvertently fixed in the form of an intramedullary nail. So this was a case where then we had to go in after giving him neoadjuvant chemotherapy, resect the entire femur and do what we call as a total femur replacement. So a total humerus or a total femur replacement, depending upon the disease extent or whether an intervention has been done inadvertently earlier or not, can also be done. A similar type of a processes can be used for a proximal femur osteosarcoma as well. What about diaphyseal osteosarcomas? These are a few examples which we have treated in various manners. That's a mid-femur diaphyseal osteosarcoma, which has been resected. This is called as an intercalary resection, where we have used a vascularized fibula for reconstruction and a long plate. And you can see that over the time, the fibula has beautifully hypertrophied, and the patient has got an excellent functional outcome. He is able to do his full knee ROM, to all his heavy activities of daily living, and absolutely has no functional deficit. There are other ways of doing the reconstruction. That's a very young boy and sarcoma in the mid tibia. And here what we have done is that resected the intercalary part. We have done a joint, growth plate, epiphyseal plate sparing resection, done an extracorporeal radiotherapy reimplantation. And you can see that that particular graft has united well. The radiated bone has united well with the host bone, and in fact in the follow-up x-rays you can see that both the growth plates are growing in length as well, proximally as well as distally, and the patient has got an adequately good function. There are other means. If you have got the expertise available, we can do a combination of extracorporeal radiotherapy and a vascularized fibula, which is combined together. That probably gives the best functional outcome, and that's the patient of a mid-femur osteosarcoma who has been treated in this particular fashion. And you can see that vascularized fibula and the allograft have both beautifully united with the host bone, and the patient has had an excellent functional outcome. Pathological fractures, as I mentioned earlier, is not a strict contraindication to limb salvage surgery. This particular patient was treated with chemotherapy and then reconstructed using an intercalary mega processes, as you can see in this particular slide. Pelvis is another site, though not very common, where you get to see osteosarcomas. They are not very rare as well, and these are the cases which are again treated in a similar fashion, treated in the form of internal hemipelvectomy, and various types of reconstructive modalities can be done. In this particular case, an ischiofemoral arthrodesis has been done. But currently, our favorite methodology is doing something as what we call as a mesh plasty. We just resect the tumor, use a Prolin mesh to sort of create a pseudo joint, and the patient has an excellent functional outcome in these particular cases. As you can see that there is hardly any limb and abductor lurch, and even though the entire hemipelvis is missing, he is able to walk on that particular extremity. Children less than 10 years or 8 years are a particular age group because of their small bone sizes, because they keep on growing and they would have a limb length discrepancy. The option of mega processes is going to be extremely costly, because these are the expandable mega processes, either the invasive ones or the non-invasive ones, which are expanded by using a magnetic coil and a magnetic mechanism. But these are prohibitively expensive. So what we prefer to do in children less than 8 years of old with osteosarcomas is the procedure called as a rotation plasty, wherein we resect the tumor, shorten the extremity, rotate it externally 180 degrees, and allow the ankle to substitute for the knee. The advantage is that the children adapt to this particular procedure really very well. They don't feel as if they are walking on an, they feel as if they are walking on a natural limb. They have a knee control, and psychologically it's a much better outcome. This particular patient has just been fitted with the prosthesis, and though he has a limb right now with adequate muscle strengthening, his gait will be much better later on. All these particular cases that I've shown you are fantastic to know the results, to see the results, but there can be a lot of complications, both intra-op, early post-op. There could be implant-related complications, and there could be disease-related complications like local recurrence and distant metastasis. And the person who's going to treat this particular patient has to know how to pick up these complications early and how to deal with these complications so as to maintain the adequately achieved functional outcome in these particular cases. One has to note that almost 50% of these particular cases will require revision surgeries. Average 3 to 4 surgeries are required in the patient's lifetime, eventually later on. And in almost 50% of these patients undergoing repeat surgeries, the final functional outcome may be same or worse than an amputation. So we need to select our patients very carefully. One has to remember that if we select the cases well, if we have good surgical skill and experience, if we plan well, make use of the improved technology, and make use of the advances in adjuvant modalities, limb salvage is still possible in majority of our osteosarcomas, though they are extra-compartmental. I thank you very much for your patient listening and for inviting me and giving me this opportunity today. Thank you very much.
Thank you, Dr. Yogesh, for excellent keynote lecture. I think I would ask Kaushik, you can moderate this session since Kaushik is a practicing musculoskeletal oncology surgeon in Narayana Hospital. So you can start discussion and questions here.
Hi, sir. Good afternoon, sir. And, thank you everyone for this excellent discussion. And my question to Yogesh, sir. Sir, is there any specific indication for upfront surgery, means after the diagnosis with a biopsy, instead of going through the neoadjuvant chemotherapy protocol as explained by you very nicely? Is there any specific clinical scenario when you plan for upfront surgery?
Absolutely. See, we have to remember that neoadjuvant chemotherapy does not really make a difference in the overall survival of the patient. It has got a various other advantages that I just mentioned in my talk. But if there is a patient who's got a purely intraosseous disease, there is no extraosseous component, you're sure on the MRI that you are going to be able to resect the disease completely without any spillage, with adequate margins, and do a reconstruction, then those are the patients where you can just go ahead with an upfront surgery and give the patient chemotherapy later on in the adjuvant manner. And that will not really change the overall survival for that particular patient. Most of our patients present to us late, they are already extra compartmental when they come to us, when they get diagnosed. And these are the cases where we would like to use the chemotherapy so as we can reduce the vascularity, we can sterilize the satellite nodules, we can give them a good fibrotic capsule so that the dissection becomes easier, there is no spillage, and we can reduce the extraosseous soft tissue tumor component. So those are the various advantages. Yes, if you have a patient who has only purely intraosseous disease, then you can just go ahead and resect upfront.
Sir, as you all know, this bone and soft tissue tumors are very rare as per incidence and prevalence. So experience from the surgeon point of view and everybody who are involved in the sarcoma team is very less. Apart from the centers dedicated in treating the sarcoma, give us some idea what is the role of multidisciplinary approach in treating this bone sarcoma patients from the other allied surgical means pathology and radiology point of view, because the bone tumors are variegated in appearance from radiology and both pathology point of view. Can you just give an idea, sir, for multidisciplinary team?
Absolutely, yeah. Because of the shortage of time, I did not dwell much on that particular point. But all these particular patients have to be treated by what we call as an MDT or a multidisciplinary team, as Kaushik was mentioning. This particular MDT is composed of the treating clinician, the medical oncologist, the surgical oncologist, sometimes the radiation oncologist, pathologist, radiologist. So these are the key people involved. Sometimes we need the vascular surgeons and the plastic surgeons as well. So what does this team do? This team just comes together, discusses the radiology and the pathology of that particular patient and decides what would be the best possible treatment modality for treating that particular case in that particular patient. So that is what an MDT is all about. And it is of extreme paramount importance to, have a discussion in the MDT regarding the management of these particular cases so as to give the best possible outcome to that particular patient. So yes, we have to have a team that is involved in treatment of sarcomas, and you need to have a team which is experienced so as to give the best possible outcome.
Sir, I have a question.
Yes, sir.
So while we take the biopsy, is it necessary to send the sample to two labs, or just one lab is enough?
Extremely important question, very, very practical question. It's a protocol that we should not split the sample in 2 or 3 different containers and send it to 2 or 3 different pathologists. The reason being, as Kaushik was just saying, that all the sarcomas are pretty heterogeneous. What do we mean by that? We mean that the sarcomas can look different in different areas of the tumor. So one particular pathologist, if he gets a sample from one area, he may report it as a low grade. If another pathologist gets a sample from another area, he may get just necrotic tissue, is not able to comment on that, and other person may call it as a very high grade sarcoma. So in order to be fair to all of them, what we need to do is that send all the sample to one pathologist, get the slides and blocks prepared from that particular pathologist, and then maybe you can have a second or a third opinion and can just circulate the blocks to any more pathologists that you want to. That's an extremely important thing, so as to be fair to all of them. Our pathology colleagues also need to be very, very well versed with the bone and soft tissue tumor pathology, because that's a very tricky field. And we have seen a lot of areas where our patients have had a wrong surgery done just because of a wrong pathology report. But you should not split the sample. Send the blocks to other pathologists if you want to have another opinion.
So one more question. How many cycles of chemotherapy do you get before operating on such patients?
Yeah, so typically there are various centers even within India which follow different protocols. So there could be a 2-drug protocol, there could be a 3-drug protocol, depending upon the choice of the medical oncologist in that particular institute who's treating bone and soft tissue sarcomas. If I have to put it very broadly, we are looking at about 3 to 4 cycles, which we give to our patients before the surgery. After every cycle, we have a look clinically so as to assess whether the patient is responding well to the chemo and not progressing. If the patient is progressing, probably we will take him up early for surgery. But if he's responding or she's responding well to the surgery, then we would give at least 3 or 4 cycles to have the maximum benefit.
One question, sir.
Yes, sir.
One basic question. As we know, osteosarcoma and osteomyelitis both affect the metaphysis.
Yes.
How to come to a diagnosis at an early stage?
Yeah, that's again a very valid and logical question. Typically, if we are speaking of only osteosarcoma, these are late presentations, typically around 15 to 19 years of age. This problem is more when we are talking about Ewing sarcoma and infection, because Ewing sarcoma will be seen in the first decade of life, so will be osteomyelitis. And these are the cases where we have to be extremely, extremely careful. We have to rely on what the X-ray picture looks like, what the MRI picture looks like. The MRI in a case of osteomyelitis will show you those typical fat sparing areas, which will not be seen in a neoplasm, in an aggressive neoplasm like a sarcoma. Typically, a sarcoma will give you an extraneous soft tissue component in cases which are presented to you a little later. And obviously, the clinical signs and symptoms and the clinical findings will also be very important. How the extremity feels like or looks like is also going to be an important input. What I would like to say is that we have to keep that clinical and radiological context in mind and then do an appropriately guided biopsy so as to have adequate tissue for diagnosis, get it reported from an experienced pathologist so that we have got a good report and a conclusive report. Typically, if there is a dilemma regarding an osteomyelitis vis-a-vis a sarcoma, we also take material for culture and gram and Zn stain so that we can have that particular report backing up our pathological diagnosis as well.
Thank you.
One question.
Sir.
Yes, Panag sir. Welcome, Panag Bhushan sir. Panag Bhushan sir is president of our Central Zone of Orthopedics. He is professor and HOD in Dhanbad Medical College, Patliputra Medical College, Dhanbad. Welcome, sir.
In cases of recurrence,
yeah.
In cases of recurrence, do you ever advocate immunotherapy?
Recurrence of osteosarcoma, you mean?
Yes, yes.
So when an osteosarcoma recurs, there are multiple things that we need to look at, where is the local recurrence, whether it is resectable by doing a limb salvage, whether it is associated with any distant metastasis or not, and more importantly, what has been the DFS or the disease-free survival rate, so the survival time or interval. So if that particular patient has had a recurrence and metastasis at less than say 1 year duration from the completion of his initial treatment, then that means that we are dealing with a subset of cells which has metastasized or which has recurred, which has not responded to the initial chemotherapy. And then we are looking at a poor prognosis. Immunotherapy is not really that commonly used in cases of osteosarcoma. There can be second line chemotherapy that can be put to use, but our experience is that even after changing the chemotherapeutic drugs in these particular poor responders, the outcome is really, really very poor. So immunotherapy in its truest sense is not the choice of treatment in osteosarcoma, unless and until we are speaking of some trial setting or trial scenario.
One question, sir.
Yes, sir.
Well, in many cases, we usually advocate the core needle biopsy. In which scenario you say we go for the open biopsy, a failed core needle biopsy? In which cases?
Yeah, so again, good question, and something that I had not covered in my talk because we had a few minutes to go through everything. Genital biopsies, we prefer genital biopsies almost all of our cases now. Hardly any of our cases undergo open biopsies. If our genital biopsy fails to give us a conclusive diagnosis in the first go, what we try to do is that repeat a similar genital biopsy, get a frozen section done. While we are doing so, if we have that particular facility in our center, typically we do have, all the sarcoma centers have a frozen section facility. Ascertain that we have viable tissue and representative tissue that is going to give us a final histopath, which is going to be conclusive. But if we don't get a conclusive diagnosis after doing repeated genital biopsies, maybe 2 times or 3 times, then probably we may have to think about an open biopsy. Also, if the clinical picture and the radiological picture is not matching the biopsy report, then again, we might have to think about doing that. But I would say that as far as possible, open biopsies are not to be advocated. They are not to be done because they would probably lead to more damage than be of any use. A needle biopsy can give you tissue from the depth of the tumor. You can just use the same entry point and go in different directions and take cores from different areas. That is not what an open biopsy will allow you to do. Open biopsy, you'll have an access only to the superficial area of the tumor. You cannot really go in multiple directions, multiple depths. So those are the problems. So we still prefer doing a needle biopsy.
I had a question here.
Yes, sir.
As a routine, we are using serum LDH and alkaline phosphatase as a marker for the activity of osteogenic sarcoma.
Yes.
So, is it always raised in these conditions only, or there are other conditions in which LDH may still be raised?
Yes, there are other conditions where they can be raised. Basically, we don't use them as a diagnostic tool. We are basically using them as one prognostic marker in one way. Number two, we can use them to assess the response of treatment in these particular patients. So once you are treating them with chemo, if the alkaline phosphatase, that's a bone turnover marker which is reduced or which starts falling down, then we know that this particular patient is responding to the chemotherapy. Obviously, there will be other pointers like clinically the mass reduces in size, the patient complains of lesser and lesser pain, or he says that the pain has gone away. So those are the other pointers. But yes, if you want to have an objective tool, alkaline phosphatase in osteosarcoma and LDH in Ewing sarcoma can be pointers as far as the prognosis and treatment response is concerned. So we will not be using them as a diagnostic tool. We will be using them for prognostication.
Thank you, Yogesh sir, for excellent talk and discussion. I think Anand, we have next case presentation by Dr. Anand Garg.
Good afternoon, and thank you for giving me the opportunity to present this case in this meeting. I am going to be present a case of Ewing sarcoma of proximal humerus. A 10-year-old male presented with the gradually progressive swelling, which seems to be clinically a malignant swelling, and presented with the open biopsy scar mark, belongs to be a lower socioeconomic status. And this patient present with the open biopsy confirmed report is a case of Ewing sarcoma involving upper two-thirds of the humerus, which is very close to the physis. As per protocol, I did the PET CT of this patient, and which comes to be a non-metastatic Ewing sarcoma. I did pre and post chemo neoadjuvant MRI, which shows a good response with the chemotherapy, neoadjuvant chemotherapy. As per protocol, definitely wide resection of the tumor and the reconstruction of the tumor. And the option available for the reconstruction is the custom-made megaprosthesis, nail segment dysplasia, vascularized fibular graft, ECRT, and cryotherapy. As per in our setup, we need something economical because of such background, durable, biological, and it should be the technical simple. So for me, the custom-made megaprosthesis is not possible. Nail cement displacer may be an alternative option if no other option is available. And the thing is, it is not biological. Vascular fibular graft, ECRT, these two have a technically demanding and more logistic needed. So I plan for the cryotherapy, which seems to be best suited for my case. So I did plan for this patient with a wide dissection of the tumor, pedicle humerus from the elbow, and cryotherapy of that pedicle humerus and reconstruction or reimplantation of the humerus in the original place. So wide dissection of the tumor was done. Then pedicle humerus was made, and it make the multiple drill and make suitable the humerus for the liquid nitrogen cryotherapy. In cryotherapy, there is a 3 steps. First step is a 20 minutes in the liquid nitrogen. Humerus is wrapped with the polythene, and it can make the upside down in the container with the liquid nitrogen, and it will dip for 20 minutes in the liquid nitrogen. Then after 20 minutes, for 15 minutes, it is thawing in the room temperature to come down the temperature in the room air. Then 15 minutes wash with a normal saline to make him the normal temperatures where we can put it again. I did put it back and plated the whole humerus to prevent the pathological fracture further, and for the attachment of the nerve, attachment of the muscles and tendons all around the plate, and with the multiple drill, I make the some mesh capsule also. This is a 1 year follow-up the X-ray and patient clinical picture. Regarding cryotherapy, a little bit, it is a very simple, economical, and it needs very short treatment of time. It is had a osteoinduction, conduction property, and it preserved the cartilaginous matrix. It had a elimination of the need of bone bank, and it provides a good attachment of the tendon and ligaments. And as for biological, it has no chance of infection, immunogenic, and it provides sufficient biochemical strength. Regarding one new therapy is coming, is cryoimmunology. The protein denatured by the liquid nitrogen act as a anti-tumorigenic for other site near distance metastasis. And regarding disadvantage, it degenerated the cartilages, and you did not get the whole specimen for the histopathology after the surgery. So regarding this, liquid nitrogen is a excellent option and a cost-effective reconstruction method for malignant bone tumor, and it had a very low and no recurrence and distance metastasis. So this is the case of my presentation.
Stop sharing your screen. Kaushik, the case is open for discussion. You can start.
I just wanted to ask, what does he mean by the pedicled humerus? You could not see the pedicle after cryotherapy.
Because the humerus is taken out from the shoulder joint, it may become a feed from all over the joint, from the capsule and muscles, the free area all around that, and it make like a pedicle and may make the upside down to dip in the liquid nitrogen container. So it make like a pedicle. That's why I tell you.
Yogesh sir, your opinion on pedicle cryo?
Yeah, it's an excellent technique and very good case, Dr. Anandkar. The biggest advantage of using cryotherapy currently that we find is that you don't have to do the osteotomy. So you don't really have to worry about non-union if you are planning to do something like an ECRT, or you don't want to do something like a completely artificial reconstruct like a nail cement spacer or a prosthesis. So you don't have those related complications. My only worry about doing pedicle cryo is that extra stripping that we have to do of the bone, far further down than the disease extent in the intramedullary area, because you have to rotate the entire limb and dip it into the liquid nitrogen. So you end up stripping quite a lot. And another worry is actually if you have to be really extremely careful to sort of isolate the entire surgical area by using different sheets and plastic drapes, so that when you drill holes within the tumor, you're not really causing any contamination. So apart from these couple of worrisome things, if we are very careful intraoperatively, that's one of the good reconstructive modalities that is now available to us.
Sir, I have a question. At what stage can we go for cryotherapy, and what are the tumors amenable for cryotherapy?
Maybe Dr. Garg can take that question.
Yeah, it was actually.
Actually, a few papers are published. Many cases they will do this case in the even osteosarcoma, Ewing sarcoma of the distal LPD, where you can able to make the pedicle possible to dip inside liquid nitrogen. In that cases, you can able to do that. In most of the malignant bone tumor, the main request is you can able to dip the tumor inside the liquid nitrogen and protect the normal tissue from the burning of the liquid nitrogen. That is the important issue where you can able to do. So making a pedicle is very important. Where you get the length and make the rotator to dip inside that. That is very important. In most of the cases, many cases of distal TB, they did not, in many papers from Japan, they take out the whole of the tumor, not making the pedicle, take out the whole of the tumor, dip inside the liquid nitrogen and fix it again back, like ECRT. They take out all the, and even they show the good result with that. Even you cannot make able the pedicle, remove the tumor by dissection, remove all the tissue from the tumor, dip inside, and again fix it with the plate and bone grafting. That is also showing the good result in many cases from Japan.
So is an osteogenic sarcoma treated by cryotherapy?
Yes, the paper is already published. It is not depends on which tumor. It is the malignant tumor. It kills the tumor cells. That is the basic principle. You can utilize in osteosarcoma, Ewing sarcoma, both of them as well.
Okay, thank you. So is it only once we have to do or repeated?
No, it's when you do the liquid nitrogen cryotherapy, many studies shows is the tumor free. The tumor is tumor free. If it is recurrence, little bit remaining tissues there in an airway surrounding distal part, then that is separate. So that is the recurrence. But for surgery, that is single surgery. For that case, it is a single surgery.
And would you also allow neoadjuvant chemotherapy along with it, or any chemotherapy along with it?
As sir told just before talk, if you go for upfront surgery, no need to go for the neoadjuvant chemotherapy. If you think about a worry of the soft tissue extension, a micrometastasis, a distal surgery, definitely you go for the neoadjuvant.
Sir, after cryotherapy, what are the chances of recurrence?
Your voice is breakdown, sir.
Am I audible?
Yeah,
Yes.
now audible. Yeah.
So after the cryotherapy, what are the chances of recurrence of the tumor?
And though I did only one cases and try searching for another cases, but the thing is, what the publication is did I have read that there is no recurrence till now, and Dr. Yogesh Panjwar will focus on this is better.
Yeah, basically, we are not much worried about the local recurrence more than any other reconstruction modality. Typically, the local recurrences that we see would be in the soft tissues because one of the satellite nodules that has not been removed at the time of surgery. Otherwise, we expect the local recurrence rates to be comparable with the other reconstruction modalities. Kaushik, you want to add something over here?
Sir, I think sir has a concern that whether the cryo will be optimum for the tumor kill. So to answer the question, for one patient of a pedicle cryotherapy due to postoperative surgical site infection, we had to remove the entire calcaneum and we had to send for a culture as well as biopsy to explore whether there is any recurrence or residual disease or any osteomyelitis. So in the biopsy specimen, our histopathologist confirmed that it was entire tumor kill, no viable tumor cells was present. So that gives us a confidence that regarding the tumor kill of the cryotherapy. And another thing for all our pedicle cryotherapy cases, we post cryotherapy we send the soft tissue, the frozen soft tissue as a surrogate marker regarding the tumor kill. That is also documented as a postoperative biopsy specimen that there is no viable tumor cells.
Okay, thank you.
How do you protect the neurovascular bundle, Anand? Is there normal drape or you use something else?
I use first two sheets, then normal drape, then a cling drape that we use in the arthroplasty. And I put the whole limb except the pedicle part, whole limb in the cling drape, and again sit, then protect. So you have to be protected. You feel by your own finger also. If you feel cold and very cold, that in that case you again put the cling drape is very useful in that cases.
Dr. Garg, in the pedicle cryotherapy, generally it is shown that for long bones, you have to open the medullary canal and evacuate the disease from the medullary canal. So in this case, do you did a hole through the articular cartilage and curated the material in your case?
No, I did multiple drill. I did the multiple to prevent the pathological fracture, but I didn't make them open the medullary canal and curate all the things. I didn't do that.
Thank you, Anand, for excellent case presentation. Dr. Govind, we can go with our next talk.
I'll start.
Yeah.
May I welcome Professor Panak Bhushan sir for his talk. Panak Bhushan sir.
Bhushan sir has lost connection, I think. Yeah. Bhushan sir? We can't. I think we can go with Dr. Alok talk. I think Panak Bhushan sir, we are not getting him. Yeah. Alok sir, we can start your talk on recurrenceicity. Yeah.
Is it on the screen visible?
Yeah. No, not sir. It's not shared.
It's not shared. I can see it here.
No. Sir, open your PPT, then share screen. Then share screen. Sir, click on share screen.
Okay. Share screen.
And then you can see your PPT in the.
There.
Yeah.
Yeah. Now it is coming.
Yeah, but it is not coming. Where is the PPT? We can't see the PPT, sir. Only part of your desktop is coming here. We can see only part of your desktop.
Now?
No, sir. So you have to click on that slide, sir. The PPT slide.
The PPT slide I have made full screen.
No, we can't see. Sir, what you have to do, first you have to share your screen, then you have to click on your PPT.
Okay. Then I have to share.
And then share. Yes, sir. Now it's coming. No.
Still not there?
No, sir, not see. We can't see.
But you start your PPT. Let's see whether we can get it.
No, so click on Zoom. See, there's a PPT there. You can click it. Just click on Zoom, sir.
Click the Zoom.
Yeah.
It's going to back meeting.
I think PPT was there, sir. Just this one, sir. This is your PowerPoint, I think. Yeah. Click on this PowerPoint, sir. Now PowerPoint. Yes.
Yeah, this one.
Yeah.
Okay.
Click. Yes, sir. It will come here. Hopefully.
Sir, you can stop screen sharing, open PPT in the background first, sir.
Yeah, it is open in the background.
Yeah.
Please open PPT in the background, sir. When the PPT is open, then you can again do sharing from here. It will show the window of presentation.
Or you can mail your PPT to me, sir. I can share it from my side. By the time we will start.
I'll share it with you.
Just send it on my mail ID. Let me see, sir.
Yeah, I'm sending it.
So, Panak sir, are you ready? Panak sir, I think we can't see Panak sir. There is some network issue. So, Dr. Govind, you can start your case. I think you can present your case. Yeah.
Okay.
Rajiv, what is your email?
Sir, just I'm sending it in chat box.
Is it visible, Dr. Rajiv?
Yeah, it's visible. Make it presentation mode.
So my topic of presentation is resection, reconstruction, arthroplasty of distal radius GCT. Giant cell tumor is a benign but locally aggressive tumor, and always there is a chance of local recurrence, malignant transformation, and also potential for metastasis. Usually it is seen at the end of the long bones after skeletal maturity, and the usual location is metaphyseoepiphysis, but occasionally it is limited to the metaphysis. Giant cell tumor accounts for approximately 5% of all bone tumors, and the most common location is distal femur, then comes proximal tibia, and distal radius is the third commonest site. Usually it affects 20 to 40 years of age group, and females are more commonly affected. Various treatment options are available in the literature, and these include extended curettage with or without reconstruction, using autogenic or allogenic bone graft or bone cement. Resection and reconstruction with vascularized or non-vascularized proximal fibula, that is fibular head arthroplasty. Next is resection with partial wrist arthrodesis, and then comes the resection with complete wrist arthrodesis. Curettage and bone grafting can preserve the joint functions, but it has been associated with high local recurrence rate, about 27 to 54%. Curettage and bone cement has recurrence rate low, but it is 8% to 15%. Walther was the first to describe the use of free non-vascular proximal fibular graft to replace the resected distal radius. And most of the authors have reported various success rates with this procedure. Now the problem with the GCT is it remains difficult and challenging management problem because there are no absolute clinical, radiological or histological parameters that can accurately predict the tendency of any single lesion to recur or metastasize. Reconstruction of the wrist after excision is a challenge because high functional demand of the hand and the percentage is younger, limited surrounding soft tissues, and the proximity of the adjacent nerve and tendons. So, pre-operative assessment should be very careful about history and examination, site and size of the tumor, including relationship with the surrounding structure, and routine X-rays, chest X-rays, CT scan, and MRI if indicated, serum calcium, phosphorus, alkaline phosphatase to rule out the hyperparathyroidism, FNAC, and tissue biopsy. Radiologically, it can be graded according to the Campanacci. Grade 1 is well-defined border of a thin rim of mature bone and bony cortex was intact. In grade 2, lesion had relatively well-defined margin, but there was no radio-opaque cortical rim. And in grade 3, lesion with fuzzy borders suggest a rapid and possibly a pre-permeative growth of the tumor. So goals of the treatment is ideal treatment goal is to eradicate the tumor and preserve the joint function. So goal is to achieve complete removal of the tumor, decrease the risk of local recurrence, and to preserve as much wrist function as possible. So you can go with volar or dorsal approach depending upon the extension of the tumor lesion. But one should be careful to leave 1 inch of normal distal radius was excised along with the tumor with safe margin in all cases and preserve the neurovascular bundle and tendons. Reconstruction of the bony defect was done using ipsilateral proximal fibular pyrograph. Fibular graft size should be 8 mm more length than actual required was taken to prevent carpofibular subluxation. The articular surface of the head of the fibula was placed over the scapulolunate articular surface and fixed to the carpals with K wires. The excised end of the radius and the transplant were fixed with a small DCP, and another K wire was fixed transversely to stabilize the new created fibulo-ulnar joint. The limb was immobilized in a long arm cast for 12 weeks. And these are cases. The first case is 28 years male with history of pain and progressive swelling in left forearm. These are the pre-operative X-ray. This is 3D CT scan. These are showing that the lesion has broken the cortex. These are CT scans. The excised tumor mass approximate the length, and these are intra-op fixation. This is the graft harvest size, immediate post-op, and this is 1 year post-op follow-up. This is the functional range of motion of the wrist. This is another case, 17-year-old female with history of pain and swelling. This is excised tumor, intra-op, post-op. These are follow-up. And there is a gap at the radiofibular site. So it will go into the non-union. So the take-home message is removal of the distal end of radius will jeopardize function of the forearm, compromise range of motion of wrist, and cause instability of the wrist unless a reconstruction be undertaken to restore anatomy. The clinical behavior of GCT is unrelated to histological or radiological grading, and thus the decision to either salvage or excise the tumor bone is based on the ability to achieve stability and function. Most authors agree that the completeness of the curettage and excision is the single most important factor to prevent recurrence. Several studies support proximal fibular replacement after distal radius excision. It has got low donor side morbidity, predictable and satisfactory functional results are there, and relatively free of major complications. The more localized lesions are best treated with curettage. but extensive cortical destruction and large soft tissue component usually need a in-block resection. And a careful clinical and radiological assessment of the distal radius GCT and judicious treatment plan is the key for successful outcome of this lesion. Thank you, sir.
Thank you, Dr. Govind, for excellent presentation. Yes, Anand, do you have any question? Kaushik? Dr. Yogesh? Yeah.
One question, Dr. Govind.
Yes,
How
sir.
long these patients go comfortably as per your experience? How long these patient, operated patient, tubular
Yes, sir.
transplant in GCT, lower radius, how long these patients go with comfortable functional outcome?
We don't have longer follow-up. We have at least 2-year follow-up in the first cases, and that patient is satisfactory. There is limitation of the wrist motions is there, quite obvious in the picture, but otherwise patient is happy and he is doing his routine work and his duties.
So I have one question for boss.
Yes, doctor. Yes, doctor.
Yeah, what approach do you use? The normal Henry's approach for such tumor?
I usually prefer lazy accepted incision, depending upon whether it is dorsal side extension or ventral side extensions. So I don't exactly follow the Henry's approach.
So it can either be dorsal or
yeah, you can modify it. I usually follow the lazy accepted incision, as is shown in the picture.
And what is the recurrence? There is no recurrence after doing this procedure.
The key of successful is to complete eradication of the tumor mass. If there any left behind, it will recur definitely. So I have shown the excised mass. It is totally extra periosteal and there is no breach of the tumor tissue. So in my cases, there is no recurrence, but there is definite recurrence.
Because the only worry about GCT is recurrence.
Yes.
And is there any other method? Anybody can of the faculty can take this question. Is there any method to prevent recurrence after doing curettage for GCT, curettage and bone
Some
cement?
cytotoxic chemicals are there, just like phenols or cryotherapy. You can do prevention for the recurrence. And you can, if the cortices are intact, you can add bone cement as a filler, and it will also act like a tumor killing due to its exothermic reactions.
Is there a role of radiotherapy or chemotherapy to prevent recurrence in GCT after doing surgery?
I don't have any experience about that.
Kaushik, you say?
Alok, sir.
The giant cell tumor are radio resistant and chemo resistant. They are not sarcomas which will be responding to these. So it is basically patient genetic workup which we will be discussing later. It is your surgery whether you have been able to achieve the margins properly. And if you are going for curettage, because at times the patient's own joint will definitely be having better function, then how are you cauterizing? Are you using zoledronic acid? Are you using cryotherapy? Are you doing cauterization, liquid phenol? Are you going for the extended curettage where you are bringing up the bone away from all the necrosed tissues, ridges, tumor goes off, and then the whole shell remains without any tumor cells? So it is that, but nobody can guarantee that following a curettage there will be no recurrence. Following excision with reconstruction, the recurrence is due to the stage at which you are operating. Latent, nobody is doing excision. Active, some people are doing like Dr. Govind has done. And when it is the aggressive tumor, the whole tumor is a bag of bones, a capsule surrounded by the destroyed tumor. So here if the tumor has infiltrated out and you have not been able to wash it out, you have to go for a recurrence. You have to be ready for it. I'll discuss it in next paper.
Can I make a couple of points? One is regarding the technique for distal and radius giant cell tumor. So about that, what we prefer to do is a technique what we call as an ulnar translocation. What we don't use the proximal fibula for reconstruction. I'll come to the reason for that. What we do is that we osteotomize the ulna along with its muscle attachments, and then we shift it back into the defect of the distal end of the radius, and then do an wrist fusion. In our experience, that gives the patient a very stable and painless joint. The patient retains entire pronosupination once we do that, and he's able to do all his functional activities without any problems. The issue with the proximal fibular arthroplasty we have found out is that typically when we do it for an large distal and radius tumor, we can't retain the capsulo-ligamentous structures, and we can't really give the patient a very stable joint. So most of them at a later follow-up would end up having some sort of a carpal subluxation with pain, stiffness, and inability to do all their activities. So that's the reason we tend to do more of a wrist arthrodesis than try to save the function in the wrist. For a very small intraosseous type 1 Campanacci distal and radius giant cell tumor, we will still go ahead using doing a curettage, extended curettage and reconstruction. Issue regarding reducing the local recurrence rate in a curated giant cell tumor, not necessarily the distal and radius, but other sites, is to have a proper manual thorough curettage. That is the single and the most important thing that helps us in reducing the local recurrence rates. And obviously use of high-speed burr. So nowadays when we say curettage, we mean that we are using high-speed burr, we are using pulse lavage, we are using hydrogen peroxide. There are many surgeons which use other adjuvants like phenol alcohol, like an argon laser, or a simple electrocautery that is used to burn the entire internal surface of the tumor cavity. There have been some meta-analysis which have shown that these may not be completely contributory to reducing the local recurrence rate, but you have to use a high-speed burr. That is found to be the most important factor. Whether you use bone cement or bone graft for reconstruction, there have been recent reports which have said that the bone cement does help in reducing local recurrence rate to a certain extent, and it's easier to pick the local recurrence rate, local recurrence in the bone earlier as well. So that is one point. Another point regarding preventive agents, medical agents to be used for reducing the local recurrence rate. Denosumab is what we use preoperatively to make a resection easier, avoid spillage, and hence reduce the local recurrence rate. So all our resections in which we have used denosumab preoperatively, we don't use it in a post-operative scenario. In the preoperatively used denosumab, we have had 0 local recurrence rates because the resection is complete and there is no spillage of the tumor cells. Post-operatively, if you have to use, there have been some studies in vitro as well as in vivo where they have found out that zoledronic acid is useful to a certain extent in reducing the local recurrence rate. So if you feel that the particular patient has an increased risk of local recurrence rate, you could give him a few doses of zoledronic acid on a monthly basis. How many, we are not really very clear. Maybe 3 or 4 doses, monthly doses, by taking the appropriate precautions that we normally do while giving IV zoledronic treatment. So these are the few points that I just wanted to put across.
What is the duration between 2 doses of zoledronic acid?
If you have to give, we don't give it in all our patients. If you have to give, maybe 3 or 4 doses with a monthly 4-week gap in between.
Oh, thank you.
So there are centers like the Chinese University of Hong Kong, where Dr. Shekhar Kunta has done some work. They prefer 1 or 2 doses of zoledronic acid pre-operatively, followed by maybe 2 or 3 doses post-operatively. And they have said that it has helped immensely in reducing the local recurrence rates. But the thorough manual curettage is what remains as the most important factor in achieving the lowest recurrence rates.
Anant, you want to point something?
I want to add few comments. The important thing is whether we are sure, even in clinical radiologically, biopsy is a must. We should biopsy even if we are sure clinical radiologically it is a giant cell tumor. And second thing, before going any resection, whatever plan of modality, to rule out any soft tissue component, MRI is also must. So before going for any resection of distal end of the radius, even in grade 3 Kapanaki, before proceeding, must biopsy and MRI to rule out any soft tissue components, so that we can even able to manage these cases with the pre-op denosumab and curettage and grafting or cementing also.
Sir, I have a question for Dr. Gupta, sir. Dr. Govind, sir.
Yes, sir.
Sir, am I audible?
Yeah, you are audible.
Yeah. Sir, my question to Dr. Gupta, sir, you have shown nice reconstruction. My question is the K-wires you have intercarpal, radiocarpal K-wires you have put. You keep the K-wires for how many months or how many weeks? And do you repair the small intercarpal ligaments as Dr. Yogesh has already described to delayed carpal collapse?
Sir, I did not. I keep the K. First question. I keep the K-wire for 3 months with the support, and then we remove the K-wires, and then we go for gradual range of motion exercises. And in my cases, we have not repaired the ligaments.
Thank you, Dr. Govind, for excellent case presentation. I think now I will share the screen for Dr. Alok Agarwal, sir.
Thank you, sir.
Yeah. It's there?
It is there.
Yes.
Yeah. All right, sir. Please, sir. You can start. I will play slide for you. Yeah.
Thank you. So continuing with the discussion on giant cell tumors. Well, if you have gone for a conservative procedure like curettage, extended curettage, whatever amount of the curettage, macroscopic cell remnants cannot be denied. And that is the cause of recurrence in most of the cases. Please change the slide for me.
Yeah, I have changed, sir.
But here I cannot see.
Anant, Dr. Govind, you can see the next slide?
No, sir.
No. Only first
Only
slide.
the first slide is visible.
Right, is like that. Now?
It's a protected view. It's a protected view.
You have to cancel the enable editing.
Just I will do enable editing.
Okay,
Just
okay,
wait.
fine.
Yeah. Yes, sir. Now it's there?
Yeah, it is visible.
Yes, please.
Recurrence in giant cell tumors is fairly common, and this occurs mostly following curettage, but also following curettage with cauterization, curettage with cementation, and extended curettage. Most of the cases treated at this stage by excision and reconstruction do well, but repeat recurrences and metastasis to the lungs has also been reported in the literature. In these cases, we'll be showing you some of our cases. So we'll be reporting here about 8 cases of GCT in the last 20 years. And they were the GCT of the proximal femur, distal radius, distal femur, first metatarsal, middle phalanx, fibula. And all these cases were treated with repeat surgeries. And in one case of proximal fibula, the patient is continuing without any progress on abendronic acid, 150 mg orally. Most of the discussion goes around denosumab or zoldronic acid, but even abendronic acid has been doing good in this case. So just like Dr. Govind's case, this is a giant cell tumor of the distal radius. And you can see it is Campanelli gate 3. There is no tumor at all, and the whole tumor is only lying inside the capsule. So you have to go for only excision with reconstruction. And this was done with the epilateral proximal fibula. And in our experience, we have done 28 cases with the same side fibula. And we never repair the capsule. We do a plating. We stabilize the wrist like Dr. Govind did. We keep a plaster above elbow for 3 months and below elbow for 3 months. And by this time, there is so much of stability that these patients, even with a follow-up of now of 20 years, are doing very good. They don't have any stiffness, neither do have they any pain. So coming to my topic, so this was the reconstruction. Next slide, please. So 1.5 years later, you can see the lungs are clear, but he had 2 ganglion-like small swellings on the wrist. And FNC proved them to be GCT and they were excised. Please change. So here is the follow-up you can see. He can make a nice fist. He can do all work. And he's very much happy. Next slide, please. So this was an X-ray of a 16-year-old girl on the first side. And you can see that as she is a child, her epiphysis is preserved, growth plate is preserved, and she was treated by curettage and bone grafting. Next. And then you can see this osteolytic expansion surrounding the grafting, that is recurrence. So at this junction, this has to come out and the proximal fibula was done. And that is the lady. This is of course little weakness in the AHL, and this is quite common at times because of stretching. Sometimes it is just because the muscles have lost their insertion, so it becomes weak, although not a foot drop. And this girl came at the age of 25 with 2 children. She was well married, with doing very good results. Next, please. Yet another case, a GCT of the proximal femur was treated with cementation. As you can see, the cement. So she came to us after 6 months with a pathological fracture neck of the femur, and then the whole tumor has been excised, and we have done a limb preservation system with a total hip and a constrained prosthesis. Next, please. And this is the girl. And following treatment, later she came to us at 2 years with a baby. So they are doing very good in life also, apart from having no recurrence. Next. This is the little finger, the middle phalanx. And you can see a large osteolytic lesion. And this is not the first tumor. This is after 2 surgeries. It is the 3rd recurrence. And all the people now hearing that it is the 3rd recurrence and the scarred tissue on the finger have advised that we should go for amputation of the little finger because it will cause no much problem. But he did not want the finger to go off. Next. So that is the finger you can see. And that is the excision which has been done. And the patient was given monthly arendronic acid. And this is the graft from the iliac crest. And it has been reconstructed. And over time, the KY has gone out. The finger has survived. And the patient is doing good. Now it is a 3-year follow-up with us without any recurrence. Now this lady had a giant cell tumor which was treated with curettage and cementation at some other center. And you can see here, can we go back? You can see that apart from the local recurrence, she also had soft tissue recurrence. You can find out the soft tissue recurrence only on a MRI. Having a soft tissue recurrence along with the giant cell tumor recurrence is not a contraindication to limb salvage. And so this hole has to come out. Next. And you can see it was the year 2006. So we went for a long intramedullary nail and used the fibula. It is called as a Necking's procedure. And this lady now, even in 2020, last year I got a follow-up. The bone has grown very big. She is walking without any problem. And she has now discarded her weight relieving caliper also. Next. And patella is this bone with the giant cell tumor very rarely. And due to the accessibility, the patella was excised. But you can see now here multiple cannonballs even after excision and the local recurrence. And she did not require any treatment and she was lost to follow-up. Next. So we had soft tissue recurrence in a case of GCT of distal radius. Another I had shown you two local recurrences, one managed by ibandronic acid, 150 mg oral tablet and one by excision with reconstruction. And they keep on coming to us. The rest were treated with excision with reconstruction and all are doing good without any recurrence. So this does not mean by any way that excision with reconstruction, that soft tissue involvement cannot leave back the tumor cells for a recurrence, but in our cases we did not get it. So let us discuss. Next slide, please. Well, metastasis is well known in GCT following repeat surgeries. Curettage is also known as intralesional excision, which leaves macroscopic tumor remnants, which bring about recurrence in spite of cauterization, cementation, or extended curettage. Our 7 cases with repeat surgeries did not metastasize and also did not show any local recurrence in long run. Next. This diagram I have taken from the sarcoma clinic, and you can see here that will be the sarcoma, that will be the soft tissues with satellite lesions, and that is the skip lesion. So the cause of recurrence will be the satellites into the soft tissues. There will be the skin, which is the limiting factor, with satellites coming into the skin. And then if you have got a skip lesion, they are the cause of recurrence. So Balke et al. Reported that involvement of soft tissue was an independent predictor for giant cell recurrence. When the soft tissue surrounding the tumor was not affected, the recurrence rate was 16%. But when the soft tissue was affected through tumor invasion, the recurrence became 30%. Next. Well, it has been suggested that the Campanacci classification may be associated with GCT recurrence, and higher the grade, higher may be the rate of recurrence. But some people feel that it is the stage of the disease, initially latent, then active, then destructive, and then aggressive. So it is when you catch the tumor, that is when you have to treat. Well, Prosser observed that recurrence of GCT was closely associated with the involvement of cortical bone. When the tumor did not break through the cortical bone, the recurrence was 7%. And when the tumor broke through the cortical bone, as in a pathological fracture, the recurrence was coming to 29%. Next. And before determining the surgical method for the treatment, the destruction of cortical bone and the involvement of soft tissue should be evaluated as a predictor for GCT recurrence. Next. Studies have shown that the recurrence of GCT is not associated with the Campanacci grade. You should never make an apple and orange equal. They are different. So it is the surgical method which is the primary factor influencing postoperative recurrence and not the Campanacci grade. Next. And although no relation could be established between Campanacci grade and GCT metastasis, we still recommend excision and reconstruction for all cases of aggressive GCT and GCT presenting with recurrences. Although the lesion is coming at the second decade, early third decade, so to preserve the joint, one should work hard at this age with curettage, cauterization, extended curettage and cementation. But once there is no bone, you have to go for excision and reconstruction. And same, you should avoid repeat surgeries. So we have done it in recurrences also. So what is the future? The future you can see is the KI67, the mutant P53, the P63, and overexpression of C-myco oncogenes. CD147 is under research as a marker of recurrence, and it has been found to be an adequate marker for GCT recurrence. Now we all know that apart from how you operate, it is the genetic background of the individual which makes them susceptible or resistant to recurrence. So normal patient got the GCT. So it was because of the gene with him, and the recurrence also at times will be related to the gene CD147. And by having it done, you can have a prognosis for the patient, whether it will be recurring or not. So thank you.
Yes,
One
Ashok, sir.
question. I have one question, Dr. Alok.
Sir.
In operated case of GCT lower radius, as Dr. Govind has also given a hint, when you do reconstruction with upper fibula, have you come across this non-union at the site of lower fibula and radius? And if it has happened, how did you manage it?
Sir, as we discussed, all the 28 cases that I did, we went from the dorsal approach. We never went, separated the vessel or went like that. Number two, once we come to the frontal quadratus, that is the bed which separates the soft tissues and vessels from the tumor. So there is nothing like recurrence. If you look at the diagram given in the old volume of Campbell, they had used to do a Z osteotomy and they used to fix it with 2 screws. So that was a very lousy fixation. And we thought that it will not work and it will break. So apart from our first case, we never did it. In all our cases, we went for a DCP, a 7-hole DCP with 3 holes on one side and 3 holes on the other side. As I told you, in all our cases, because what we have read, that the fibula, which is not a vascularized fibula, so it gradually loses its vascularity, cells, and it comes up with creeping substitution. So by the time of 4 months, when you think that the patient is losing patience, that is the time when the bone is the weakest. So it needs protection from 4 to 6 months. So we gave a plaster above elbow for 6 months, 3 months with above elbow, 3 months with below elbow, and then we started. So meanwhile, with the fibrosis, the wrist also become so stable that none of the cases had subluxation or weakness or pain, and they were doing good work. I will agree with one thing, that 6 months is a long time, but that is what we had given.
Sir, I have a question for Alok sir. In a mild grade GCT, do you first go for confirmatory diagnosis, or do you straight away go for curettage and send the tissues for biopsy?
So we are the followers of Yogesh Panchavag only. He was our colleague at TMH. None of the bone tumors, if it is bigger than 2 centimeters, if it is deeper to the deep fascia, or it is in the bone, we will never proceed till we have done a biopsy, whatever small it is. And so many times it came out to be a plasma cell cytoma, osteonic sarcoma. So never proceed with it. You may be burning your fingers.
That's Dr. Alok Agarwal's humility at its best. We learned a lot more from him, and he would like to put it the other way around. Thank you so much, sir.
Alok sir, one question, please. Sir, are you using cancellous bone graft at the radius and scapular junction? Radius and fibular junction?
Actually, if you want to put cancellous bone graft, you have to give another incision at the iliac crest or proximal tibia or the olecranon. So we don't use it, no. And neither do we use an electric saw for taking out our fibula. We do it with a low speed, either drill an osteotome, or we use just a giggly wire saw. And the bone is not that necrotic with heat that it doesn't hold. We don't put any graft there.
Okay, sir.
My question to Yogesh, sir. Sir, whether in the recurrence of GCT, where you already operated 2 times recurrence is there, where you evaluate the patient with any genetical marker? Yeah, right now you are not doing that.
We are not following any genetic testing for any recurrent GCT. Our policy about treating the recurrent giant cell tumors is pretty much the same way as we would follow for a primary giant cell tumor of a bone. So we don't think that it's any more clinically or pathologically more aggressive than the primary giant cell tumor as it would present. So we would go about the same way as we would treat an untreated giant cell tumor. We would see if the joint is salvageable. We would try and salvage the joint. If it's a extraosseous tumor or extraosseous mass, then we would Campanachi grade 3. We would see whether we have an adequate bone left behind to do any sort of a reconstruction, whether the articular cartilage is damaged or not, whether the tumor mass is in all the 3 planes or the 4 planes or limited to only 1 or 2 planes. So basically, we would treat it the same way as a primary giant cell tumor.
So one more question. What about the lung metastasis in GCT?
Yeah, so lung metastasis is typically seen anywhere between around 2 to 6%, so around 4% usually. Again, it's not related to the location. It does not have a lot of sex predilection, or it's not related to the Campanachi grade or a pathological grade. We don't know why exactly one particular or only 4% of giant cell tumors would metastasize to the lung. Treatment is basically they are not life-threatening. If we have only a few pulmonary metastases of giant cell tumor, we would now treat them with denosumab and see and do a pulmonary resection or metastatectomy. By doing pulmonary metastatectomy, we would resect them all, and a patient would go on to achieve cure. If they are unresectable, if there are a lot of pulmonary metastases and then unresectable, then those sort of patients would probably go on a very long-term treatment with denosumab and zoledronic acid, if surgical resection is going to be very morbid or not possible medically or surgically.
One more question, sir.
Yeah.
Like malignant bone tumor, we resect pre-neoadjuvant chemotherapy margin. We take the margin as before the pre-neoadjuvant chemotherapy area. Like in GCT, if it is recurrence and we after recurrence give the denosumab, what is the recurrence margin for resection margin in recurrence cases?
Yeah, so basically, if you are planning to do a curettage after giving denosumab, then the local recurrence rates are considered to be extremely, extremely high. So there have been now a lot of international and national publications coming in who are talking about recurrence rates around 40% to 60% if you are going to do a curettage after giving the patient denosumab. So giving denosumab, say about 4 to 6 doses, and then doing a curettage is going to be a bad, sort of a prognosis as far as the local recurrence is concerned, because almost 40 to 60% will recur. Even if you have to do that, probably what we would do now is to give only 2 or 3 doses at the most, and then go ahead with the early curettage. When we are doing a curettage, we will see to it that we have used a CM control, and we have gone to the edge of the bone, edge of the cortex, and taken out almost all the fibrotic tissue, all the osseous tissue that has formed as a result of giving denosumab to that patient preoperatively. After giving denosumab, if you are planning to do a resection, then that's not a very big problem. You have almost no recurrence rates after giving denosumab, and if you are resecting a giant cell tumor. The problem is only when you are going to do a curettage, because that is where you are not going to be able to judge clinically what exactly is a complete curettage, and there might be a few cells, stromal cells, which are trapped in the fibrotic tissue or in the osseous tissue of the rim, which may later on give rise to local recurrence.
Thank you, Yogesh sir. I think Panag Bhushan sir, you are ready with your PPT. There was some network issue. Please unmute yourself, sir. I think there is some network issue with Panag Bhushan sir.
Yes, hello.
Kaushik, you can. Yes, sir. Can you share your screen, sir?
Yes.
Yep.
Hello.
Sir, can you share your screen?
Yes, I'm sharing. Share screen. Yes. It's okay.
No, we are not getting it. Yes.
Can you listen to me?
Yes, sir. We can listen to you, sir. We can't see your screen.
You cannot.
So
No, sir, we can't see.
we can't see your presentation.
Presentation is not visible, sir.
The slides are not visible, sir.
If I do share those photos, can you see something
No, sir.
No, sir.
right
Sir,
now?
first open your PPT.
Yes.
Yes,
Can you
sir.
see anything?
Yeah, yeah.
Yeah, but you are presenting from your mobile,
Yes.
so it's not coming in a full screen. So it's like we are getting a part of vertical screen like that.
Oh, I'll just change it to the. I'll just find out. Share iCloud Drive. Is it okay?
It's same format, sir. It's like we are not getting the whole whole slide side. It's a central part of the slide we are getting.
One third of the.
1/3 of the slide.
Now?
This is.
Maybe yeah. Yes, sir.
Yes.
Yes, sir. Now you can start, I think. Yeah. Bhushan, sir. I think some network issue is there with Dr. Bhushan, sir.
Actually, it is raining here.
Yeah. Same is in Calcutta also. Yeah, Kaushik, you can start sharing your screen. I think Bhushan sir will join later on. There is some network issue, so his video is also not running.
Video is
Kaushik?
not right.
Yeah.
Yes, sir.
So you can start your presentation. Bhushan sir, I think.
Ask Bhushan sir to send you email.
Should I start?
Yeah, I will ask him. I will call him. I will call him. Or Rohit, you call Bhushan sir. Na? By the time you call, I will call you. Yeah. Kaushik, you share your screen.
Should I start?
Yes, yes.
Good afternoon, everybody.
We can't see your screen, Kaushik. Yes.
It's good now.
Make it in presentation mode. Yes.
Respected senior teachers and colleagues, thanks for inviting me for this August podium. Few case-based discussions. Male patient, the chief since last 6 months. Trauma. This is a plain X, as you can see on the lateral view. There is a classical textbook picture of a primary aggressive bone tumor with a classical periosteal reaction in the bottom. Aggressive kind of periosteal reaction on the medial and the lateral surface, and also on the entry on the distal end of the femur.
Sorry.
The surface of the distal end of the femur with a soft tissue component. So, as per the protocol, we did a contrast enhanced MRI imaging covering the entire compartment of the femur. As you can see, there is an altered signal intensity of the femur starting from the distal epiphysis to the proximal epiphysis with a huge, large extraosseous soft tissue component. And if to get the closer view, the proximal epiphysis, there is the altered signal intensity is going almost up to the proximal epiphysis, crossing proximal to the lesser trochanter. So the disease is going up to the proximal epiphysis on the proximal meta-epiphyseal region. The core needle biopsy was osteosarcoma. It was a 6-year-old male patient. The PET CT non-metastatic. So as per the protocol, we treated the patient with a curative intent. After completion of the neoadjuvant chemotherapy, now the call has to be taken by the surgical team. So how to plan for the management for this patient? It's a non-metastatic challenges where the intent was curative and the surgical option is it may be a hip disarticulation, which is not readily accepted by the patients. A self-expendable prosthesis at the cost of a huge expense, and the conventional tumor endoprosthesis. Conventional tumor endoprosthesis will not fit considering the skeletal immaturity of the patient. Self-expendable endoprosthesis will incur a huge amount of and these are not the biological reconstruction methods also. And hip disarticulation is a morbid surgery, is not the patient and relatives are not convinced most of the times. So we plan for a biological reconstruction as Dr. Yogesh has already described in this first lecture. This we did a rotation plasty. It was a Winkelmann type B 3A rotation plasty, where the entire femur was resected. Was resected with a preserved neurovascular bundle. This is a sciatic nerve, as you can see. This is a sciatic nerve. This is a sciatic nerve, and this is a femoral neurovascular bundle, and this is a resected femoral segment. This is a femoral resected specimen, as you can see, and we reconstructed with. We did a 180-degree resection of the 180-degree external rotation of the distal end of the leg, and we fitted the proximal end of the tibia into the acetabular socket with a suture. As you can see, this is a suture anchor. We sutured the ligamentum teres with a suture anchor into the proximal tibial metaphysis and did a capsular suturing of the proximal of the hip joint capsule with the knee joint capsule, and the soft tissue reconstruction of the proximal hip joint plexus with the knee joint extensors and the vice versa. So this is a type of biological reconstruction. This is a type Winkelmann type D3A reconstruction, and the philosophy behind this reconstruction is when the patient will start weight bearing, this proximal part of the tibia will be pushed into the socket of the acetabular socket, and as because he is a skeletally immature patient, the proximal part of the fibula, proximal part of the tibia will be remodeled just like a proximal femur metaphysis. It will be remodeled in the shape of a proximal femoral metaphysis. So this is a 2-year post-op. As you can see, this is a special post rotation plasty orthotic device, and this is a 2 years. The patient is disease-free. He has successfully completed the adjuvant chemotherapy protocol. At present, he is disease-free, no metastasis, no local recurrence, and now he has been advised for touch mobilization since last 1 year. This is the functional video at the end of 2 years. Proceed to the second case. These are a few challenging cases in the pelvis. The specific challenge in case of pelvis is number 1, because of 3-dimensional geometry of the innominate bone. Number 1. Number 2, the close proximity of the neurovascular bundle. Number 3 is close proximity to the abdominal and pelvic viscera, and the huge amount of blood loss and etc. And to get a clear oncological margin, which forms the basis of the oncological surgery, never to compromise with the oncological margin, as already described by Dr. Jo. So these are the challenges in pelvic reconstruction and pelvic sarcoma cases. This is a 23-year-old female patient. She was a medical intern. She presented with a chondrosarcoma. The only presentation was a dyspareunia. She got married in internship, and the only presentation was a dyspareunia. No other bile bladder incontinence, no other pain, nothing, no swelling, nothing, etc. Only dyspareunia was the presenting complaint, and the diagnosis was done by, initially the clinical diagnosis was done by a gynecologist while doing a parvaginal examination. Then she was referred to us, and the core needle biopsy was done. It was a chondrosarcoma. PET scan, whole body PET scan was non-metastatic, so we treated the patient with a curative intent. As the disease, as the sarcoma was arising from the superior and inferior pubic rami, so the patient landed up with a type 3 internal hip pelvectomy. And as we all know, for type 3 internal hip pelvectomy, no reconstruction is required. So we did no reconstruction, only resection was done. And this is the, as you can see, this is the resected specimen. This is the immediate post-operative working video, as you can see in the hospital ward. It's in Australia, and she sent a working video through WhatsApp. This is at the end of 4 years. Post-operative, she is disease-free. So the take-home message for this type 3 reconstruction, this is resection with a clear, adequate surgical margin in case of type reconstruction to achieve optimal functional results. This is a case of 28-year-old male patient presenting with a involvement of entire half of the right innominate bone with the iliac blade going up to the acetabular rim. This is the diagnosis of Ewing non-metastatic. We did a 1 plus partial type 2 internal hemipelvectomy. This is the resected specimen. As you can see, this is a part of the. We did for all our pelvic cases, we plan for a reconstructive surgery. Apart from the type 3 reconstructions, we do a 3D printing, and we get the 3D printing, and we plan our pelvic cuts, the resection cuts in the 3D printed model. And if any kind of biological reconstruction is planned, like ECRT, we do a pre-contouring of our plates that we'll discuss in our later cases. This is a planned surgical resection as demonstrated from the 3D printing software. This is the pre-contouring of our plates. These are the pre-contoured plates, and the same plates we are going to use on the next day in the intraoperative. This curtails a lot of intraoperative time, because you don't have to fight with the contouring. The irradiated autograft, ECRT, we treat the resected sarcoma bone with a 50 gray radiation dose, and the same irradiated autograft is used. And fixing and following the principles of the acetabular and the pelvic fixation, the bone is fixed. The completion of the adjuvant chemotherapy, the patient developed surgical site infection. After 2 debridements, the infection was not cured, so we had to remove the entire irradiated bone and all the implants. But at the end of 3 years, this is a surgical. This is the post-operative final X-ray, as you can see, and this is the functional video at the end of 3 years. Patient can walk. Patient can drive. He came to our clinic, and he also came to our IMSOS meeting in Kolkata driving himself. At the end of 2 years, he is completely disease-free. This is a 56-year-old male patient with a pleomorphic sarcoma involving the entire left iliac wing. We did a internal hemipelvectomy with a mesh plasty, as described by Dr. Yogesh in the beginning. It is a mesh that is used for hernioplasty that will help in growing a fibrosis and a solid pseudoarthrosis. So this is a cost-effective, durable reconstruct. This is a resected specimen, and as we can see, this is a functional video. The patient sent the video. This is as you can see, he himself sent the video. This is at the end of 1 year. So the radiology, as per the post-operative radiology, is quite frightening from the X-ray at the end of 1 year. The last pelvic reconstruction case is the case of chondrosarcoma. Following the same principle, on the 3D printed model, we planned our dissection cuts, and we contour plates we use the next day. This is at the end of 2.5 years. As you can see, there is a evidence of early changes of avascular necrosis in the superlateral quadrant of the proximal femur. As you can see, this is a complications in the kind of surgeries. At the end of 2.5 years is a post-operative X-ray, and here's an acceptable range of mobilized with a at the end of 1.5 years, he has completely joined his duties. This is my last case at the presentation of 26-year-old male patient with osteosarcoma, non-metastatic osteosarcoma of distal femur. As you can see, the huge soft tissue mass in the anteromedial aspect of the distal femur and the open biopsy scar mark. This is a plain X-ray, pre-chemotherapy X-ray with a huge large soft tissue mass. As we can see, there is a periosteal reaction. And this is an altered marrow signal intensity with the intraosseous and extraosseous component. The most important point is in prescribing the X-ray and the MRI is to cover the entire compartment of the disease, the entire compartment of the bone. As you can see, there's a clear-cut difference between the pre-chemo and the post-chemo clinically, as well as radiologically. There is a soft tissue entirely diminished. The pain has diminished, and as per following the sarcoma principle, the entire biopsy, it may be a core needle biopsy or open biopsy, the entire scar, biopsy scar has to be excised en masse with the surgical specimen. This is a resected specimen, and this is a reconstruction with the modular endo processes. This is the end of 3 years. This is the functional. You can hardly delineate which side is the operated side.
Calling using Wi-Fi or data? Calling using Wi-Fi. Record audio.
Nice presentation, Dr. Nandi. It is now open for questions.
Hello, sir.
Hi, sir.
It's going on or it has ended?
It's still ongoing.
Okay, sir. Just want to confirm. Okay, sir.
Yeah. We are at the probably the end of the discussion, waiting for some questions.
Right. Tell me what's done, sir. I'll stop live. Dr. Raman is not there.
Dr. Raman looks not amongst us.
It looks like he's been logged out, probably accidentally.
No problem, sir. Yeah. Okay, sir. Please tell me when we are ending, sir. Okay, sir.
Hello.
If Dr. Panak Bhushan is ready with slides, we should proceed. If we have no questions.
Are you ready, sir?
My slides are ready, but I'm not able to connect it.
Sir, I have sent you Dr. Rajiv's email.
I think network is very poor.
हाँ डॉक्टर राजीव
हेलो
भूषण सर का आपका वो भेजे हैं ईमेल लेकिन उनको समझ में नहीं आया है शायद
Okay, thank you.
हेलो
छोड़ना पड़ेगा लीव करते हैं
Definitely, okay. Meeting has ended.
Am I audible? Hello.
Yes, you are audible, sir, but screen is not.
Sure. So my topic is not great. I can just talk. And it has been my fate since many of the conferences. Yeah, Govind must verify it. I have to give orations and suddenly mic goes off and many times I had to speak extempo. Even the Rajiv is also a witness to it. Yeah,
Yes, sir,
Rajiv.
you are extraordinary in such things, sir. You can go ahead.
We are waiting. We are waiting
And
for your
today,
oration.
this is probably my age and audibility. But anyway, next time onwards, it can't happen. I will do a good rehearsal. Actually, I'm in Devghar and I'm not with the laptop. That may be one of the reasons. So what I had to talk about the basic thing which we have to discuss, because when the patient comes, we see the patient, we diagnose it. And once we diagnose it, we came to the conclusion. Once the cases are diagnosed and the cases which has been shown to us here by, of course, the masters of the subject, it is difficult to replicate, I must say. May it be Nandi, may it be Yogesh Patwan, whatever it is. It is difficult to replicate. What I wanted to talk about the common thing when we get a tumor case, we should not immediately get scared of it. We should try to investigate it, come to the conclusion, and if we can do anything, fine. Many times when the patient comes, we don't know whether to give the X-ray or CT or MRI or PET-CT. So coming downwards in a descending order, and many times, since we are not technical people, so we do not know what is what and where to use it. CT scan, we are well aware of. MRI for the tumors, we are not very well aware of whether it is going to help us or not. And PET-CT, again, we are not sure that in which cases it is useful, which cases it is not. So actually, I had to start from the very beginning that we get the X-ray lateral obliques. We should see the size of the tumor. We should see the site of the tumor. We should see the margins and how easily it is melting in the surrounding bone. We have to look for the periosteal reaction, which we usually miss. And the thin speckled vertical striations with the sunray appearance is usually confused. Codman triangle is kept below the sunray appearance in the virulence or aggressiveness, where it should be higher than that. And even the difference between the moth-eaten lesion and the permeative lesion is difficult to describe. I do not have the X-ray, so I cannot share it. But the fact is that we have to have a real assessment of the case, whether the case is going to be treated by us or going to be shifted to a higher center. And a simple X-ray can give a good amount of information. Whenever we talk of surgeries, we usually talk of Janssen tumor, Ewing sarcoma, and osteosarcoma. And if we look at all the lectures in all the places, we are confined to only these three cases. We do not even think of adenocarcinoma or histiocytosis or even PNET and other things. So what my approach was today to look into the problem when other cases can be there. There can be an island of bone, how the island of bone is addressed. There can be a simple osteochondroma and what are the difficulties and mistakes we do. And many times the osteochondroma is left for years and it comes as a full-blown 3 times of the diameter of the femur. Thigh, I mean, 3 times of the diameter of the thigh. And resection part-wise, anteriorly, posteriorly, medially. So when we talk of tumors, we should not confine ourselves to only these three tumors and its reconstruction. Second thing, what we wanted to tell, I wanted to tell, that while making the diagnosis, we must assure that whether we can do it or not. We had the last thing about the tibia, something which we all do, and it excites all. Tumor is not a very popular thing because it is not done by all. It is confined, so we do not take interest also. So doing the X-ray, doing all sorts of things, as I told you again, I repeat it: size, site, shape, whether it is bony or it is the cartilaginous island, which is it's a whorled or speckled, whether it's ivory type or the bony condensation at the margins, all these things give you a message. And these messages can sometimes help us to diagnose the cases, and many a times we are able to do it. Even the osteosarcoma, I was in PGI Chandigarh, I had seen that it was treated by three great surgeons of that time, and still the osteosarcoma was missed. One small step done by our senior, Dr. Nagi, who was president of IO also, he just cut the bone, he sent it for the X-ray. At that time, image was not there, and he confirmed it. So small little things can help the patients in these cases. And again, coming back to the same level, I had all the X-rays of all the other diseases than these three diseases, which I wanted to show you, so that this can just ring a bell and understand the things. Besides, whenever we get the cases which are returned from the higher centers, and as you know, that in the medical college of the Ranchi and Dhanbad, these places, we get recurrences, not being treated, or even the failure of the treatment. As I asked Dr. Yogi, that if immunotherapy has any role, or the second level of chemotherapy of osteosarcoma has a role, because finally we have to face the patients and its results. So this was the basically talk on that, showing the things other than these things, and surgical bonanza and surgical excellence and dissection, which is not everybody's cup of life. I think this was my message, and without slides, talking anything more than that, when it is 4 o'clock, 2 minutes. So we have reached the end of the time also.
Thank you very much, sir.
And I tried a lot. I sent videos of things to Rajiv also. I know the local boys, Govind and Rohit. These are our dynamism personified. ये लोग गतिशीलता के मानवीकरण है.
Thank you for encouraging words, sir. Dr. Rajiv is there or not?
Rajiv is not visible.
Yeah, Rajiv is visible.
Rajiv is visible. Yes. How can he be missed?
I think we can conclude now, because already we have crossed the 4 mark.
But anyway, I promise you, from next time onwards, it won't be there. I will be personally tutored by Rajiv. And Yogesh, your thing was very good.
Thank you very much, sir.
A person of your authority should always be there to take care of all these things.
Thanks a lot.
Besides, never versatile our Rajiv. Thank you very much.
Now it is time to conclude now. Dr. Rajiv?
Yes, our host. Dr. Rajiv. Conclude it, please.
Raju sir, your volume, you're not audible, sir.
Sir, we are not audible, sir. Raju sir. Sir, you're not audible, sir.
Dr. Rajiv, you are not audible. You are not audible.
So can we have the concluding comments from your side, sir?
Yeah.
Yes.
Thank you very much for all the guest faculty, especially Dr. Yogesh, and sparing your valuable time for the Jharkhand Orthopedic Association, sir, and mind-blowing lecture, sir, and it is very helpful for us. Next comes the Dr. Anand Garg, sir. Your presentation was very mind-blowing and it was helpful, and it is helpful for us, sir. Thank you very much, sir. Dr. Panna Bhushan, sir, thanks once again, but due to the internet connectivity, you are not so much presented here, sir. Now, Dr. Alok, sir, thank you very much, sir, for sparing your valuable time for the Jharkhand Orthopedic Associations. And last but not the least, Kaushik Nandi, the youngest orthopedic surgeon and specialized in the oncology, especially the ortho-oncology.
Thank you, sir.
Thank you very much. Our keynotes, Dr. Rajiv Raman, all the time he is instrumental and conducive. And thank you very much, sir, Ortho TV, Dr. Samsul Hoda, sir, for your cooperation for the live surgery, and our president, Dr. Ashok Bandwal, sir. Thank you very much, all of the faculty, sir.
Thank you. Thank you very
Thank you,
much.
sir. Thank you so much.
Thank you.
Right, Rohit. I forgot. My junior, lovely junior, Dr. Rohit.
Thank you, sir. With your permission, I'm stopping the live stream, sir.
Okay, sir.
Thank you, sir. Thanks so much for the side, sir.